my favorite doctor. He was my pediatrician. There are these people in your life that make such an impact that the course of your life will be changed. And this was the first person who had a significant impact on my desire to become a doctor. He was my first doctor. He was different, I think, than many people's experience with physicians. He cared for all his patients. He saw every single one of them and called them his friends. He would take notes about their happenings, occurrences in life. So he knew when I had a ballet recital, he asked about it. He also asked about a big math test. And so it was really my first experience into medicine with this wonderful physician who was just caring and so interested. And he always knew what was wrong. The second person who I just cannot say enough good things about was my mentor, my college professor. I don't have a picture of him. That's one of the things that I wanted to let you guys know. If there's somebody that makes a huge impact in your life, make sure you stay in touch with them. Make sure you write them a thank you card. Make sure you just let them know how you're doing. I wasn't able to contact him after I graduated college, and then he passed away shortly after. This man was so excited about science, and he just had this work ethic of steel, a sharp mind, and really a heart of gold. When I was debating on whether to go into medical school, he gave me the push I needed. And then when I was applying, he wrote just amazing letters, and he was my advisor, but also a mentor and a friend. So, okay. So next is pre-med, and move this over. So I went to college at Southwestern University in Georgetown. This is about 20 miles outside of Austin. So it's close to home. About 70% of Southwestern students who apply for medical, dental, or veterinary programs get accepted there first time. And I can say that is very true. And that last picture, 6 out of 10 of us, or 6 out of 8 of us, I'm sorry, ended up going into some sort of medicine. So I had a Bachelor of Science in Biology and Chemistry and a minor in Spanish. I was determined to do something in the science realm after high school. I loved biology, I loved chemistry. I was not sure that was where I was going to end up, but it was, and I had a great journey there. As far as my Spanish minor, I always loved Spanish, and I actually got to go to Spain during my second year of college. And if you guys have the opportunity to travel, make sure you do it. I was told that I wasn't going to be able to graduate on time because I just had so many rigors of biology and chemistry if I went away for a semester. But I did it, and I grew from it, and I learned more about myself. And so I would say if you have the opportunity, go ahead and do it. So next is med school. I interviewed at both DO and MD schools. And I didn't know much about DO school before applying. I can say I chose TCOM. I went and interviewed at a couple of Texas MD programs. And the thing I loved about TCOM was that it really made sense for me as far as my philosophy of wellness, my philosophy of health. Osteopathic medicine is a whole person approach to medicine. It's treating the entire person rather than the symptoms. And we can talk more about that if you guys have any questions, but TCOM was a great first step into medicine. In osteopathic medicine, you get to have more of a hands-on approach, and that's ONT. And osteopathic manipulative medicine is more of a comprehensive approach where you really learn about the body's interconnected system of nerves and muscles and bones. And then that training with manipulative medicine is just better understanding with a hands-on approach how everything is connected. I practiced OMT for just a little while out of medical school, but really I didn't keep up with it in my first job or my second job, and we'll talk about why in just a little while. Where I went for residency was Waco Family Practice. It was called something different back then, but basically this is an unopposed family practice residency program, which means there are no other residents working at the hospital or in the program, just family practice residents, which was an amazing experience. I did not know much about Waco, Texas before I went. I knew it was close to home, and I knew I didn't want to be in Austin just because I thought it would be too hard with my family being huge and all in Austin for me to pay attention and to work really hard. So I'm just giving you a little, or in the slide, you can see a little bit of a background of family medicine program. And this is directly from the Waco Family Medicine Program website. These are the topics and the courses that we had. So we had inpatient adult medicine and inpatient pediatrics. So that's in the hospital training. We also got emergency care training, general surgery, behavioral health, inpatient family medicine as well, pulmonary, maternity care, and the list goes on. And so really what I wanted to portray here was, as a family medicine physician, you get to see all types of patients. You get to see children, you get to see adults, you get to see geriatrics if you want. There are also specialties, so you can go on to a fellowship in family medicine. So that's extra training after your residency. And the family medicine residency is 3 years, but after that, you can go to a fellowship for sports medicine. You can go into a fellowship for geriatrics. You can even go into a fellowship for maternity care, which I thought I wanted to do. So I got accepted to the Austin. At that time, it was the Austin Fellowship for OB-GYN after family practice training. And I decided not to do it only because I really wanted to be able to deliver my own babies. And as a family medicine physician, as a resident, you get to practice delivering babies, and I got to deliver around 200 babies. But as a family medicine physician working in a big city, I wasn't able to do that, basically because of hospital certification. So I decided not to do that. This is a busy slide, and basically it just shows you kind of the breadth of family practice. We get to take care of, again, any age, any sex, any organ system or disease entity. Really where it says we draw most heavily on internal medicine, pediatrics and obstetrics, and gynecology and psychiatry. That is true. Every day I see a little bit of all of that. And it really is a whole person approach. And with the training that I have, I'm able to see family units. And that is probably my favorite part of being a family medicine physician, is that I get to take care of families. I get to take care of the children, as well as the sister, the brother of the family members. I get to take care of the mother, and the father, and the grandparents. And I get to have what's called continuity of care, which means I get to follow them through their disease and treatment, through their life. And so this is another busy slide. I just wanted to show you guys really the primary care network. You do some triage and treatment. You kind of get some resources if your patients need them. You do surveillance and monitoring of chronic diseases like hypertension or diabetes. You do preventive care, talk about diet and exercise, try to offer affordable care so we can use a lot of generic medications. And then that continuity of care is a big one for me. Okay, so in everyone's time in medicine, there is a time where you decide a job might not be right for you. So I love family practice. I worked with an insurance-based primary care for 5 years, and it was hospital-based, which means that there is a hospital system and a insurance group that I had to kind of abide by their rules in order to treat my patients. And then my second insurance-based primary care job was with a private practice, and it was 10 partners in total. And what I saw with these two practices was that I was not able to be the family practitioner, the family medicine doctor that I had trained to be. I wasn't able to take care of my patients. And then I made the decision to switch to direct primary care. And the next couple of slides will go through what a direct primary care doctor is. So what is a direct primary care physician? It's a doctor who provides care directly to the patient without third-party involvement, so without insurance. Typically, direct primary care physicians get to see between 5 to 10 patients per day. I get a whole hour if I want to take with my patients, but I can also see them same day or next day, have telemedicine visits. I have a low overhead, and what that means is I have one person in the office with me, and she is my MA. And I don't have a huge staff who's really just focused on billing or trying to answer patient questions, because I don't have a whole bunch of patients. As you can see, the patient panels are different. For direct primary care, it's about 200 to 500, and for insurance-based physicians, it's 1,500 to 3,000. I loved my time in both my insurance-based practices, but it got hard. I had to see 20 to 30 patients a day, and when you're seeing that many patients a day, you end up seeing patients for 7 or 10 minutes. And so a lot of my hands-on training that I loved so much, and the full scope of family medicine, I wasn't able to do because I only had a short amount of time with the patients. Meaning I couldn't do their cyst removals. I would send them out for that. I couldn't do their skin biopsies for their possible skin cancers. I had to send them out to dermatology. And so basically I was doing a lot more paperwork or charting when I was working with the insurance-based clinics. So what are the perks of direct primary care for physicians? The perks for physicians are being the doctor I dreamed of. I get to be the doctor I trained to be. I get to do more procedures, which is fun for me. I don't just, have conversations with patients. I get to actually treat what's going on with my hands if needed. And I get to practice full scope family medicine because, as you saw from residency training, I got trained in all different types of and aspects and specialties of medicine. And so I really am thankful that I get to do that. And I also have a flexible schedule that allows me to spend more time with my patients. So now I work for Euphora Health. It's a small clinic. It's a membership-based clinic. And a lot of people will ask, how can doctors survive if they're not charging insurance copays? And it's because I can, I offer these memberships to my patients, and they pay me monthly, and I get to be their doctor and have more contact with them, which is video calls or phone calls, emails or texting, who can practice a direct primary care model, family medicine physicians and internal medicine physicians. But there are other specialties that are joining on. And I just listed a few here, but probably all specialties have the opportunity to become more of a direct care, direct pay model. But I know many rheumatologists who are changing to this model, psychiatrists, pediatrics, But I think it works the best for family medicine because we get to see and do so much for our patients. So next we move on to a day in the life of a family medicine physician. I wrote I actually, this was my schedule kind of mix from last week, but just to show you the wide variation that I get to see as a family medicine physician. So, there's a 50-year-old who is a new patient to me with hypertension, so high blood pressure or high cholesterol. And I love these new patients with some chronic diseases because I can talk a little more about diet and exercise and really get into the full scope of family medicine. I also, next on the schedule is a 3-year-old with a fever and a skin rash. And then there's a 30-year-old patient with urinary symptoms. And so that's more of the acute care. Kind of some of the chronic cares of examples of 42-year-old male with pre-diabetes. And so again, it's more about using my preventive medicine training and lifestyle medicine training to really get into that pre-diabetes and what caused it. I get to see newborns in my practice, which I love. So next would be a newborn exam. And then that, of course, I had to throw in COVID, right? We get to really see, test, treat COVID, get a lot of patients with long COVID. Some other examples are a 16-year-old with anxiety. I also, because I get to do more hands-on in my practice, I do my own colposcopies. And what colposcopy is, it's a biopsy of the cervix after an abnormal pap smear. And you have to have specialized training, which just means, potentially get that in residency, but also you also have to have a special microscope to do that. And then I've also treated sleep issues and a history of depression, and then chest pain and bedwetting. Another one of my favorites, which I actually just got done doing, is incision and drainage of an abscess. That's when somebody has a skin infection that's kind of been walled off and formed a kind of pus pocket. You can open it up and drain it. And those are amazing to be able to do those because those really treat the patient's infection. And then again, there's another example of a breast mass. So again, get to do it all. See newborns, see middle age, see teenagers as well. I don't currently practice a lot of geriatric medicine, but if I needed to I would do it because I've been prepared as a family medicine trained board certified physician. So here's a first case. This is just an example of my one of my kind of day-to-day patients. It's a 55-year-old with increased urinary frequency and increased thirst. He also complained of fatigue, and he reported gaining 50 pounds over the last couple of years. Can you guys guess what to do next? And so I'm going to move on the slides, but maybe keep it in your head what you think you might do. So then we do a physical exam, okay? From that last slide, I am pretty much able to get a good story of what's going on with the patient. And so I could just get labs or move on to labs. But in this physical exam, we see skin darkening around his neck, shown in the picture below. But the rest of the exam looks pretty good. His blood pressure is a little bit elevated. And oftentimes that can be because somebody came in and they were just a little scared or worried or anxious about the exam. And so when we get his labs, his glucose is high, his A1C, and an A1C is a 3-month average of sugar level. And so his A1C is 6.8. And these labs are basically diagnostic of diabetes. And his total cholesterol is a little bit high too. So here's what I did for him. With that high blood pressure, you might think, well, could he have high blood pressure as well? But I didn't diagnose him with high blood pressure because typically it's two different blood pressures that are elevated. But with his diabetes, we could start medication. Some patients don't want to start medication, so we just discuss diet and exercise. A lot of times it's not drinking soda, it's decreasing sugar in the diet, it's going to a low glycemic index diet, and then adding exercise. So here's the next case. This is a 26-year-old female with swelling in her neck. Her symptoms started a couple of years ago, but she just decided not to come in. She also complained of a fast heart rate and anxiety. These are just some examples of what her exam could look like. She actually didn't have the eye issue. That's called exophthalmos, where your eyes tend to bulge. And then if you can look at the neck picture, that neck swelling is called a goiter, and that's swelling of the thyroid. And then there's an EKG, which we did in the office here. And this is just has a rapid heart rate. So normal, so it's over 100. So why would somebody have a neck swelling, eye bulging, and a rapid heart rate? I got to do her labs and figure out that she had Graves' disease, which is an immune system disorder that results in overproduction of the thyroid hormones, so hyperthyroidism. I'm treating her with methimazole, which is a medication used to block the production of hormone from the thyroid gland, and then also using a beta blocker to slow down her heart rate. And so these are just two examples, but there are lots of other examples. And actually, I went a lot faster than I thought. But I can definitely, if you guys have any questions, share more about different cases that I see. But I'll move on to my advice for pre-meds. So number one, follow your dreams. I knew very early on that I wanted to be a physician. And just kind of stuck with it. Although that changed over time, I thought maybe I'd want to go into some other type of science, some other type of medicine. I decided to not and stick with it, and basically because of mentors and advisors that could kind of give me a gentle push. Make sure you take advantage of any shadowing opportunity. So if you have the opportunity to shadow a physician, if you have the opportunity to go and volunteer in a hospital, go and work in a COVID vaccine clinic, whatever you can do, really getting hands-on experience is by far the most kind of interesting and amazing experience. You can change your mind. So if you decide that you're going to be pre-med and then decide you don't want to do it, you want to do something else, you can change your mind. If you decide even in residency that you want to pick a different residency or a different specialty, that's okay. I think just knowing that you can change your mind is important, because a lot of people kind of get stuck. Maybe doing something that they don't necessarily love. Train and practice in a location that you love. I never strayed too far away from Austin, Texas. I grew up here, my family's here. I knew I was going to end up here. And although that might sound boring, it was just something that I wanted to do, be close to my family. And it's actually even more important with kids. Plus, I love the weather, and I get to do a lot of different hobbies, like stand-up paddle boarding, or going on a boat, or running or hiking. So make sure you train and you pick a place or a practice that you love. Keep learning. There's always new advances in technology and medicine. It's amazing to me that when I started in med school, in the first couple of years of residency, we used paper charts. And you guys might not know what that is, but basically it's writing down patients or people's symptoms and the plan on a piece of paper. We kept it in a paper chart. Now everything is done through EMRs, and so technology has advanced tremendously. But also, I get to text my patients, and I get to have video calls with them, and that's amazing to me. Also, there are just so many changes in medicine. When COVID and the vaccine came around, kind of staying abreast of the knowledge and reading different research articles and reading different types of case files were important. So, make sure to keep learning. And then know that you can always create a practice that you love. Think outside the box. I got trained in a very traditional way of practicing medicine, which meant, getting the insurances and the co-pays. And now I'm working outside of that system, and I love it. I have more flexibility, more time at home with my family, more time with my patients. So make sure you kind of think outside the box and kind of create something that you love. And then these are just some pictures. I have time to spend with my family, so time to spend with my daughter, and then I have 2 other children that are younger and create a lot of havoc and stress and fun. So that is the end of my presentation. Are there any questions?
At this time, if you guys have any questions, feel free to type it in the chat. Actually, I do have a question for you, doctor. I feel like when we talk about medicine and just a lot of people just think about MD schools, and you mentioned that the DO route takes a more whole person view. Like, how does that? I don't know how that's different from an MD school.
Sure. Okay, let's talk a little bit about that. So what I mean by a whole person approach is when you get into, when you start osteopathic training, we have this OMM or OMT. And what osteopathic manipulation is, it's a mix between kind of physical therapy, chiropractic, and massage. So you get to learn a little more about how the body is connected by using your hands. When we were learning osteopathic manipulation, the different techniques, we learned about something called soft tissue. We learned about high velocity treatments, which is basically kind of cracking the neck or a joint. Soft tissue is more massage and kind of putting pressure against it. But this was extra training. So this was, you finish your didactics, and then an hour after, for another hour, you're in manipulation lab. And what I found is when I would talk to my friends from college who were going through MD school, or they were going the allopathic route, I found that I had a lot better understanding of the differences of the musculoskeletal system really early on in med school, because I was able to put my hands on somebody and know how all of those muscles and joints were connected. I also had a little better orientation of the different views of the body, whether that's, sometimes we're talking about sagittal view or front view or back view or side view. So I had a little bit more knowledge of kind of in hands-on approach of that 3D training. There probably, and I don't know the statistics off the top of my head, but I know that the majority of osteopathic schools really promote, because it is maybe embedded in the training a little more, primary care. There are other specialties that osteopaths go into or that DOs go into, but I think because of that holistic training, which means if I have shoulder pain, as an osteopathic physician, I'm trained not just to look at the shoulder and to use a pain medication or a treatment for the shoulder. I'm trained to say, okay, what's going on? Are you raising, are you raising your arm too much in your job? Are you lifting too much weight? Is it more your neck that's causing the symptoms rather than your shoulder? Are you sleeping weird? So it's maybe not treating just that symptom, but actually treating the whole person, meaning if it's sleep, then we talk about how do we change a position in sleep. And that's just an example. Did that answer? It was a long
Yes,
answer.
no,
It
did answer my question. Yeah, thank you.
And I have to say that's a really great question, because, when I was in college and I was applying to medical schools, I at first only thought I was going to apply to ND schools. I thought, no, I'm not going to apply to a DO school because I don't really know what a DO is. I've never seen a DO. And I mean, all of my other advisors were saying, try to get into an MD school. It's the one that most residencies look at. And that's definitely not true. I think as an osteopathic physician, and this was my experience, it was a smaller class that I had now, and I think there are larger classes nowadays, but I had a lot more hands-on training, a lot more one-to-one training, and I was in med school with a lot of people who had past life histories, past life experiences. Maybe they had been a financial advisor before. Maybe they had been, in some other job before. But I was really excited about that whole person approach, because I could really start moving into my philosophy of medicine and learning about it, whether it's, diabetes. So let's not just give you diabetes medication. Let's actually change your diet and your exercise regimen and just your lifestyle.
Yeah, thank you. That really does answer my question. Yeah. I have a question from Bella in the chat. She says, do you feel that you have a great work-life balance with your work schedule?
Yes, actually. My work-life balance, I will tell you, I worked with the hospital system. It's, they're big ones like San Rosa or Scott and White or whatever. But in my first 5 years of practice, I worked from 8 to 5 or 8 to 7, basically whatever the hospital wanted me to work, I was working their schedule. In my first job, I became pregnant with my daughter and had a baby, and I was breastfeeding, and I had to take these breaks for breastfeeding. And what my job kind of description was I was working from 8 to 5, no breaks. I just had a 1 hour lunch. And I said, well, can I change my 1 hour lunch and make it, 2 30-minute kind of breaks so that I could breastfeed and I could maybe eat a little and do some charts? And the answer was no. Everybody takes that 1 hour break. So I really felt like just a, person in this system, in this big system, that I was kind of told where to be, when to do things. Also in that experience, I was, in that job, I was kind of led more in the direction of Well, if a patient needs a procedure, I'd done colposcopies, which is that biopsy of the cervix in residency, and I wanted to continue that. But they were like, well, if somebody needs it, just send them to our gynecologist because the gynecologist can do it. And I was like, no, I can do it. I was trained for this. And so I was able to do them, but I had to fight in order to be able to do that because what they wanted me to see and do is they wanted me to see 20 to 30 patients a day because that's what brought the hospital money and that's what brought, kind of more people into the system. And that second job, I thought it was going to be a little different because I was working in a private insurance. And I'm sorry, I put private insurance based. It was a private clinic that was insurance based. And so basically, then I got to be in charge of my schedule. I got to say, okay, I'm going to work from 9 to 5, and I'm going to take 2 breaks. Amazing. What happened though is I saw this conflict between the business of medicine and then also caring for patients. I saw that in charge of my overhead, I was making sure I was seeing enough patients to meet that overhead. So I added more patients on. And then it wasn't because anybody was telling me to do it, it was because I was doing it to actually make a paycheck. I was saying, okay, my overhead is this much. I need to make this much. And it was never this, it was more like this. So I need to make this much in order to, pay for my kids' preschool or pay for whatever. And so I saw in that experience that I was a person who was leading the ship, but I was also beholden to my overhead. And I was also letting more and more patients kind of come in to where I actually was seeing, 30 patients a day because I was triple or double booking, which just means if there's a 30-minute slot, you may have one patient with a cold and you may say, okay, I can fit another one in, or I can fit another cold in. But with direct primary care with Euphora Health, it's been different. The flexibility that I have in my schedule is I can do telemedicine visits. And again, telemedicine visits were just approved by many different insurances during COVID. So they may not be approved after COVID, but hopefully medicine will change in general because telemedicine is just amazing. We get to do a lot, get to see a lot, and get to see people that might not be able to come into the office and can really, practice medicine in a different way. So with Euphora Health, I now have the flexibility of being able to work from 9 to 3 and then take a 30-minute break and then work from 3:30 to 6 or to 5:30. I have 3 children at home, and so I really try to do more telemedicine in the morning, then do some, in-person visits in the afternoon, in the early afternoon, late afternoon, and then get home at a good time. And I love my job. So I can honestly say I love medicine again, because before it was just, I felt like a person kind of working in a factory.
Are there any challenges that are unique to direct primary care that you face, you would say?
I think the biggest challenge to direct primary care is not a lot of people know about it, right? There's also the insurance companies because insurance companies have they have a different view of medicine maybe, and so what they offer is they can offer coverage, but not specifically coverage that may be important to a person, meaning if a person really wants to have their skin tags removed. Well, that's kind of considered cosmetic, so an insurance company won't pay for it. But direct primary care, we can do it for free. So I offer my patients any skill that I have. The problem is insurance companies, people know about insurance companies, right? They know if I need insurance, I'm going to go to the marketplace. They don't know if I need insurance, I'm going to just look up direct primary care and try to get a direct primary care doctor to be my physician. And so I think the biggest challenge is that it's just not well known. I don't see it as a challenge, but some people may look at it like it might, deter them. But for me, I get to practice hands-on medicine, and that's what I want to do. I want to be able to remove. So a month ago, I removed somebody's squamous cell carcinoma because it was smaller, and I could take the margins. I could cut out the margins that I needed to take, and so I was able to do that, and I love doing that. Whereas, if I was in another type of practice, I might have sent them to dermatology to remove it. But that could be a challenge for some. I know some people really, they don't want to do hands-on. They don't want to, do the full scope family practice. They want to kind of do more hypertension or diabetes treatment, and that works probably pretty well within the system. What else? I think those are probably the two biggest challenges. I mean, there's so much flexibility. Um, Another thing that is really interesting that I thought was going to be a big challenge, but it's actually really amazing, is that my patients get to, in direct primary care, they can get a hold of me 24/7 through text messaging, or calling. But if they have an urgent matter, they just call me on a weekend. And I got a call this weekend from a guy who had a snowboarding accident, and he couldn't move his shoulder because he said it was just so tight. And he was worried that it was going to be a nerve issue, but I was able to help him avoid urgent care, help him avoid an ER visit. And so I think for me, that's not a challenge because I know my patients so well. If I had 1,500 patients, somebody calling me and saying, "Hey, I think I might have a shoulder injury," I might think, "Gosh, I don't really know you. Are you allergic to any medications? Have you used muscle relaxers before and you just can't use them?" But in this case, I know my patients, so it's actually really great.
Thank you for that response. It was really informative. I have a question from Bella and Jasmine. They say, is there a huge difference in looking for jobs or like matching into competitive residencies as an MDO compared to MD?
I don't think so. The reason I said that, and maybe as a family medicine physician, it's a little different because, you know, probably some of the top family medicine physicians are osteopaths. But I didn't ever have a problem applying for residency, applying for any job that I've been in. I think a lot of it comes down to your personality. It also comes down to kind of your work ethic. Once you have graduated med school, whatever med school you choose to go to, but once you have graduated med school, I think there's a certain level that you've reached that people really kind of want to know if you're going to fit in a job based more off of your personality and more off of your life experiences. So it's kind of interesting that when you're applying for residency and when you're applying for any type of employment, they really ask more about your hobbies, more about what are your life experiences? Like what kind of the questions that we talked about today, like what brought you to medicine? Why did you want to be a doctor? Why do you love to, what do you love about medicine? Why do you love to treat people or help people? So all of those things become more important, I think, then. But I didn't have any issues with, I applied for, it's really interesting to me that most physicians, I think that there's a statistic, but most physicians will have at least, I think it's on average of 5 different jobs during their kind of employment time when they're a physician. I applied for my first job right during residency, kind of right at the end of residency. And that was with, again, a big hospital system, had no problems. Basically, I got it within, 2 days. They were like, hey, come on board. My next job, I became a partner in a private practice of 10 physicians. And there was never a question of, are you a DO or are you an MD? It was more, do you fit with our group of doctors and what can you bring to the table? So for me, I specialize and I love gynecology. I love pediatrics. I love more lifestyle medicine and preventive medicine. And so I could say, well, I can do my own biopsies. I can read x-rays. I can take care of pediatrics. I can, make sure that I love dermatology, so I can do my skin procedures. And so it was interesting because in that practice, I had my fellow partners referring people to me to do some of these other things that they just didn't want to do. Maybe they didn't want to do gynecology exams. So I had a female physician that I worked with who just really didn't like to do gynecology. So she sent them all over to me, which is great.
How would someone pursue a career in clinical, like the one you're working with, after medical school?
I'm sorry, could you repeat the question?
Oh, sorry. So how would someone pursue a career in a clinic, like direct primary care, after medical school?
Okay, that's a great question. So I think the biggest barrier is really just knowing about direct primary care. If somebody out of med school and residency wants to start their own clinic, they can rent an office. They have to, so most likely, board certification is important still. You have to be board certified, you can rent an office, and then you have to know a little bit about direct primary care or how to make it work. And so basically, you need to have a setup of an EMR, a messaging system with the patients, and a billing system. And sometimes those can all be the same kind of technology, the same group that can do that for you. But kind of know, there's a lot of physicians who come right out of residency and open their own clinic. Basically, they start with maybe 2 patients or 3 patients. They charge those patients a certain amount per month. I like direct primary care because it's not concierge, but if you wanted to do concierge, there's also that kind of different type of model. And what you do in that is you charge insurance. But with direct primary care, it really is about letting people know you're there, renting an office space, kind of knowing who your clientele is going to be, and then really just putting the word out. And most of the time, there are some direct primary cares who do not have assistants or MAs or nurses. Most of the time, it's helpful to have a nurse working for you or a medical assistant because they're able to help field calls, or if you need extra hands with a procedure, they can help with that. They can help, talk to patients or do your marketing. So yeah, really just kind of knowing about it and jumping into it. There are lots of books on direct primary care too, but I am available if anybody kind of decides I want to go the direct primary care route within the next, 5 to 10 years. Save my email and you can email me and I can definitely lead you in the right direction.
And one last question, what advice do you have for someone who's interested in everything?
That was me. I would say do it. If you're not sure you want to be a family practitioner, you're interested in everything, so every aspect of medicine, make sure you try to get some shadowing opportunities. Go into, a hospital and do some volunteer in the pediatrics unit. I know it's harder right now because of COVID. And so I know that it just really puts a strain on trying to do things like that. But if you can, try to talk, maybe even call up a pediatrics office and see if you can talk to a pediatrician. Listen in on these eShadowing different segments, because I think it's important to know what else is out there. When you are in medical school, you have opportunities to try out different things, right? So to try out those different things, go to the ortho clinic, go to the gynecology clinic, go spend some time, on different electives with, the research team or the radiology team. Even when I was in family medicine kind of residency, so I was already in the residency, I wanted to spend a little more time in the OB unit. So I spent a little more time in the OB unit. I wanted to work a little more in the psychiatric unit. And so I went and moonlighted, which means worked after hours in a psych hospital. That maybe was not what I really ended up doing, but I loved doing it. I got to work a little bit more in a hospital, so I moonlighted in urgent care. Take those opportunities and just do them. Another interesting thing, and I forgot about this until this question. It's a great question, but if you can, try to go for any type of whether it's a trip or whether it's kind of learning or whether it's just watching a documentary, but try to go out and go to different locations. I got to go on different trips, like one to Mexico, to a small clinic, and I went for 1 month in the summer between my first and second year of college, and it was so cool. I got to just kind of learn a little bit more. So whatever opportunity you have, grab it. If you do become a family practice physician and you love everything, great. You can still specialize. I have a lot of peers, a lot of family practitioners who will send family medicine physicians who will send their patients to me for colposcopy, who will send their pediatric patients to me because they just don't want to treat them, who will send their skin removal, their skin biopsies or their skin tag removals to me because they really aren't interested in dermatology. So find something that you love, and if you love it all, do it all. And family practice is a great place for it.
Thank you, Dr. Calderon, for a very informative presentation. We really learned a lot about osteopathic medicine. It was really interesting. And yeah, thank you very much for your time.
Yeah, thank you guys for joining. And let me, I forgot to post this, but if you guys want to learn more, I don't know if you're still seeing that. You can always follow me on Instagram, on Facebook. My Instagram is aprilcalderon.euphora Health, or Facebook is just april.calderon. And then you can always learn more about direct primary care by looking up Euphora Health. There's a lot of information on the website. Even if you Google direct primary care, you'll learn a lot. But I really want to help any person that I can. And pre-med, you guys have my heart, but I am posting a lot more about health and wellness, and I will try to post some more about just pre-med and kind of the journey into medicine, because I think it's so important. And it's nice to have a support group. So thank you. Thank you for allowing me to talk to you.
Yeah, thanks again for sharing your information online. We'll make sure to follow you.
Of course. And again, please send me, I didn't put my email up, but it is it's actually A Calderon at Euphora Health. So if anybody wants to email me any questions that they think of after, please email that. I can put it in the chat, or
yeah, that'd be really nice.
Yeah, let me see. I'm not sure if I can actually access the chat, but I will try.
There should be a chat button down